Hi, good afternoon, everybody. This is the middle talk in the middle of the afternoon, so it's going to be really hard. So I just want you to do a few quick things. Just pre-oxygenate yourself. Take a deep breath in, and then breathe out. Take another breath in, and breathe out. This is an airway session anyway. I'm listening to Stridor. I'm listening for Stridor. Take another deep breath in, and then breathe out. And if you need to do a bit of a stretch, just stretch. Kick the person in front of you. You'll probably wake them up. Now, when Andy Tech invited me to come and do a talk, he asked me, why don't you talk to the group? And I said, excellent, what do you want to talk about? ENT. Oh, excellent, that's my favorite topic. So I've got a whole day of sessions prepared. And then Andy said, you've got 20 minutes. 20 minutes? So this will be the most exciting 20 minutes of your life, actually, of my life. So this will be exciting. Now, usually when we talk about ENT, we are... Sorry, am I switching on and switching off the light? Oh, am That's what we think about when we think about ENT. You know, a group of surgeons all looking down a deep, dark hole called the ear, the nose, or the throat. And that's as much of a knowledge in medical education as well about ENT and about airway problems. You know, you just worry about a child that comes into your emergency department and they can't breathe. What do you do about it? Do you start aminophylline? Do you start, you know, and then you think about all this other stuff as well. What do you do with kids who can't breathe? Now, as a disclaimer, I'm a surgeon, so yes, I only know 3 antibiotics and 3 eardrops. And this is the A part of the ABC, you know, airway, breathing, circulation. I know the anesthetic ABC is airway, book, and chair. And I know that the surgical ABC is arrive, blame, and criticize. But this is the A part. This is the part about when we think about what is the airway problems in these kids. Now, don't forget that the airway begins at the tip of your nose. Everyone starts thinking down the pathway of larynx and intubation to intubate or not. But just remember, take a step back. You know that kids, particularly neonates and infants, are obligate nasal breathers. So just remember that in your mind, that you need to take a step back. So this talk will be EBM, which stands for Eric-based methodologies. And I'm going to just take you down my office, down a pathway to my office. And it begins at the tip of the nose and down all the way to the carina. Now, to simplify matters, and this is how I teach some of my junior registrars as well. When you think of the airway, think of it as a building with 3 floors, with a room at the front and the room at the back. There's a picture that's superimposed on that diagram that looks really nice. So the first room, top room at the floor, is the nose. What are the problems in the nose that could be obstructive? Now, by definition, any noisy breather means that there is a small part in that passage. There's a narrowing, there's an obstruction, there's something that's blocking. So think about what's in the nose. And the room behind that is called the nasopharynx. And then you go down 1 floor. What's in the oral cavity? Is there anything that's obstructing there? And then think about what's behind in the back room called the oropharynx. And then down the floor below is the larynx. And the larynx is a room with also 3 levels. And I'll talk to you a bit more about that. But what's at the front and what's around the back? What's obstructing at the esophagus, at the hypopharynx? So just think of it that way. 3 floors with the room at the front and the room at the back, and just go through what could be going wrong in that scenario. So this talk, instead of being a recipe or a formula about how to look after, how to handle a stridor, it's more of a degustation for you. And you know, if you've eaten degustation tasting platters, you might not remember the whole course, but you might remember 1 or 2 things of one of those courses that just sticks in your mind, and hopefully this talk will take you that. Now, the simplest thing in terms of examining the nose is having a good light. No fancy gadgets required. You don't need any of that fancy stuff. All you got to do is with your thumb, lift up the nose of your patient, and you'll be able to see right in with a good set of torchlight, or just your iPhone or your mobile phone. It's all got kind of a light source now. So you can do that just to examine. And you can pick up, for example, in this chart, there is a septal hematoma, just without anything at all, just with the light on, okay? And you can check for airflow, which side is blocked, with using a metallic object. You can go to the kitchen and get a butter knife and not a steak knife. You know, parents don't like you coming to their kids with a steak knife, but just a simple cold butter knife. You might actually give you a bit of an idea which side is blocked, if it's fogging or not, okay? And the next thing is putting a small little sucker into their nose. Now, always remember, to put in a sucker, to put in a nasogastric tube, stay low, go slow, because the sensors in the nose react to movement and pressure. Okay, so if you put it in really fast, it's going to hurt the child. If you put it in really slowly, I've seen lots and lots of kids who don't even fiddle or move at all. Okay, just stay low and go slow. And just remember as well, you know, this is one of the most beautiful part of the human anatomy, I think anyway, that you know, you have to travel low on the floor of the nose to get to the back. Okay, I'll show you a picture of a traumatized middle turbinate, one of the most common causes, you know, of us being involved. Let me start at the front, and we're not even in the front room yet. We're just in the balcony. They're children born without a nose, arrhynia, essentially. Unilateral, bilateral. Of course, this is a diagnosis that you can pick without a steak knife, butter knife, or any sucker. You know, it's picked up, you know, perinatally, and that's, you know, it's pretty easy. You can see whether or not the child is struggling, and of course, if they are obligate nasal breathers, then the answer will be an intubation, and then a transfer to a tertiary level facility. But if you're born with one of my patients last year had a unilateral arrhynia, but the other side was working well, so he didn't need any intubation. He didn't need any intervention at the spot. All he needed was to make sure that the good nose stays good. So by about the age of 9 or 10, as the septum starts to deviate, it starts to block his nose, and that becomes a problem for him at a later age. Okay, so that's with the nose. Now we're going to the front room. What's happening with the door? So this is bilateral piriform fossa stenosis. So the bones right at the front is pretty narrowed. And the key in this situation is sometimes just making sure that there's no booger that obstructs. Normal saline sprays will be helpful, or just giving the child a good nose, just one good nose. Sometimes the nasopharyngeal airway might be useful on one side, and that might escape, and the child might escape an intubation just by having a small nasopharyngeal airway on one side. Give the child one good nose, okay? Now, you're also welcome to elbow the person beside you if they're starting to snore. This is a picture of a child who had some difficulty with breathing through the nose, and there's multiple attempts at nasogastric intubation or sucker. And you could see the middle turbinate is traumatized up there, and the inferior turbinate is there, but the pathology here right at the front is a nasolacrimal duct cyst. About 30% of kids actually may have a unilateral nasolacrimal duct cyst that is never really identified. It just pops in the first, you know, in the neonatal period. But if you have a bilateral nasolacrimal duct cyst that is obstructive, then you have to deal with it. And sometimes it's probably an underdiagnosed condition because we put suckers in it and we actually rupture this thing without us actually knowing it. And then the child breathes. So now going to the back of that front room, choanal atresia. Everyone knows about that. And of course, it is going to be an airway emergency in a sense that you need to intubate the child and transfer to us. It's basically a blind sac at the end. And the obstruction, you could tell, if it is at the front, then you won't be able to feed the piriform stenosis, for example, you won't be able to feed the sucker. If it's the nasolacrimal duct cyst, it might be just about a centimeter behind the nose. If it is a choanal atresia, it's going to be about 4 to 6 centimeters behind the nose in a neonate. So you'll be able to tell just by passing this tiny little tube a bit of an idea of where the obstruction might be. And again, the goal is to try and give the child just one good nose if possible, okay? And then we repair them with stents, and it can get pretty crowded when you've got an endotracheal tube for other reasons as well over there. Now, in the slightly older age group, and we're just still in the nose here. It's exciting, isn't it? There's so much that we can talk about just about the nose alone. And septal deviation. Now, again, this is a problem with the older child. Now, we all have septal deviation to a certain extent. None of us are born perfectly symmetrical, and most of the time it's not a problem. But thinking that there is a lot of pediatricians and pediatric asthma specialists and other things, it becomes a problem when the inferior turbinate gets so bogged and so swollen that it obstructs the actual airway. This is probably the most common in the population of problems with nasal breathing or nasal obstruction. The most common cause is an enlarged turbinate. And the underlying cause in all of that, this is a pediatric conference, so therefore lots of balloons and nice pictures and Venn diagrams and things like that. It's, you know, about 78% of kids with asthma actually have no symptoms, whether it's nasal obstruction, rhinorrhea, itchy nose, sneezing. And so you need to think about the child, the older child, as to whether or not the treatment is surgical or whether or not the treatment is actually maximizing the asthma treatment and maximizing some simple nasal therapies. And in some of these bad cases, going from the normal paranasal sinuses with good maxillary sinuses and good turbinates. Oh, by the way, these turbinates, all of us have got slightly different turbinates and nasal anatomy. It's just like a fingerprint. The sinuses are different in every one of us, but that's just, I like it. Moderate and then severe. And in this kind of age group, when you can see things like polyps, in the more severe form of asthma, a more severe form of allergic rhinitis, you might see polyps. And the other big group that sees polyps are the cystic fibrosis kids, obviously, and they can be totally obstructive. But then you get the infective stage where you get pus in the between maxillary sinuses. And what's the answer? The answer is spray, spray, spray. Clean up the filter in the nose. It's an air conditioning filter. Just wash, wash, wash. Normal saline washers, regular uses of Flixenase, Nasonex, and other intranasal corticosteroids may actually help in seasonal treatment for that. And not many of them actually ends up needing surgery. And then, of course, the rare conditions of esthesioneuroblastoma are stuff that goes into the brain. Now, the room behind that is the nasopharynx. That's where our friendly adenoid sits. And again, if you've got a strong underlying history of allergic rhinitis, you probably have an enlarged adenoid as well. And the treatment for that, again, that simple treatment is going to be just wash, wash, wash. But then sometimes surgical intervention is required if you do have severe sleep apnea. This is a conference based around social media, so cat photos are important for social media. But really, the cat photo is just to remind me, when we go down to the next floor down, which is the oral cavity, you need to think about the oral cavity, the tongue, in relation to the rest of the mouth. We have patients with small jaw, retruded jaw, big tongue, hypotonia, small palate, high arch palate. That's a three-dimensional anatomy. And the oral cavity obstruction, in terms of breathing, can be quite challenging because a lot of them, the answer is surgical or CPAP. The surgical answer is going to be, jaw advancement, mid-face advancement, tongue reduction, tongue base reduction, which are all pretty severe. And so a lot of times what we do is going to be things like a tracheostomy, just as a temporizing measure as the child grows older in the hope that they would actually get better with facial growth. That's in the oral cavity. And then the oropharynx, where the tonsils live. This is probably one of the reasons why I'm placed here on this earth, is to get rid of these things. The oropharynx, the tonsils, this is still our biggest bang for buck surgery. What do I mean by that? Kids who can't breathe when they sleep. They get tired in the morning, they're hard to wake up, they're grumpy, they're irritable, they are behaviorally difficult, they're challenging, all because of a set of tonsils? Perhaps. There has been a pediatric respiratory physician studying this and saying that, essentially we're under-servicing. We still need to do more tonsils. More tonsils? No. But we still need to do more tonsils, and from a public health point of view, that these kids are having trouble breathing just from an oral cavity. Now, that is not an infection. That is a normal day 5 post-tonsillectomy, okay? Everyone has seen that. Now, all of these things are just the top 2 floors, and I'm not even getting into the meat yet, and I've only got 10 minutes left, or 8 minutes left. And so we're not even getting into the meat yet. But what does the quality of obstruction or noise sound like? Now, this is the part when I just want to introduce the difference between a stertor and a stridor. A stertor, so obstruction in these top 2 levels, is going to sound like a snore, essentially, because it is nasal or pharyngeal. Whereas the stridor is going to more of a laryngeal cause of quality, okay? It's worthwhile just knowing that difference, because then you'll be able to target your treatment a little bit better in that sense. The picture on the left is an adult larynx, the picture on the right is a pediatric larynx. And again, this larynx, my happy place. We all have different human voices that carries different characters. So one of the most beautiful thing on the human body is the human larynx. And again, it has 3 levels. The glottis is the true chords. The supraglottis is everything above that, which includes the epiglottis and the arytenoids. And what's below that is the subglottis. And the quality of the stridor is also different. So if you think about something that is collapsing above, that's going to give you an inspiratory stridor. If you've got something that is fixed below, it's going to give you biphasic stridor. So if you've got that's going to be an inspiratory stridor. And then if you got the that's going to give you the more of a fix, probably glottic or subglottic or tracheal in nature. What are the three things happens in each of this level? So ENT has got three problems at every level. So three problems are the most common, and that's the other thing as well, is in terms of prevalence. Laryngomalacia at the supraglottic level is going to be more common than glottic problem. It's going to be more common than a glottic problem. And the laryngomalacia, this is what it looks like. Normal larynx on the left, and then a laryngomalacia larynx on the right. Laryngomalacia, floppy larynx, is essentially dynamic supraglottic collapse. Every time the lungs suck air in, you've got stuff that falls inwards. And let's see if this works. So this is intraoperative picture of what a laryngomalacia looked like. Essentially, this arytenoids flopping in every time the child breathes. Now, for most of the time, we don't actually do anything to these kids because they're usually at about 6 weeks to 6 months. They usually recover by the age of about a year or so. But sometimes we do something to it. And what do? We basically trim the top. You're going to remember this. It's circumcision of the larynx. It's all that floppy bit at the front that serves no function. We just kind of trim it. Well, we can't trim too much because we're going to cause aspiration. We can't trim too much because it might cause stenosis. But we trim enough just to get them over that age. Tumors and cysts, that's a bit uncommon. And the most feared thing that is actually not that common anyway, which is epiglottitis. But just remember that although it is not common because of the vaccination, we still have the unvaccinated group of patients and the immune-suppressed group of patients that can still have epiglottitis. Okay, glottic pathology. I'm going to have 4 minutes. Vocal cord dysfunction, cysts or nodules, and papilloma. Again, papilloma is a disease that's on the way out because of all the vaccination that we see in our community. Vocal cord dysfunction, it could be unilateral, it could be bilateral, or it could be paradoxical. And this is a picture. So normally when we see a vocal cord at the time of inspiration and expiration, every time we inspire, the vocal cords opened up. And every time we expire, the vocal cord just closed slightly. When you've got a fixed bilateral vocal cord, you have vocal cords that don't move. So you get fixed inspiratory and expiratory wheeze. And you can see these vocal cords don't move. They just stay there. And there seems to be a contraction around the whole larynx, but there is no actual movement of adduction or abduction or adduction. And there's subglottic stenosis as well. So in this kind of situation, the two resistance at two different levels triggered this child to unfortunately require tracheostomy. A lot of them do resolve with time. We give them about 12 months to actually resolve. Actually, I'm going back. So in terms of the actual vocal cord dysfunction, of course, we know it mostly 1/3 of it is idiopathic. The other third is iatrogenic, meaning due to some cardiac heart surgery, you actually cause injury to recurrent laryngeal nerve. The last group is actually birth trauma. So, difficult labor, pulling and yanking, vacuum suction, then twos. Apparently up to about 45% of kids who were delivered may actually have unilateral vocal cord palsy that may not actually be identified at birth. Just going straight. And then there are other glottic pathologies, screamers and yellers. You get that kind of vocal cord nodules, the wallaby supporters and screaming and yelling. You got intubation trauma, just simple nodules. But most of these things will not cause any stridor. Yes, you've got the glottic web that may cause stridor because it is a true airway obstruction. Okay, papilloma disease that's going on, but it's still something worth considering in a child that has ongoing stridor. And then subglottic pathology, subglottic stenosis. Now, just remember that in an older child, or an adult, an 8 millimeter airway with 1 millimeter circumferential swelling, you get about 44% decrease in airflow. But in a child, in an infant with a 4 millimeter airway with 1 millimeter circumferential swelling, it is critical, 75% decrease in airflow. You know that subglottic stenosis, subglottic cyst, and the unusual or sometimes rare subglottic hemangioma. About 1/3 of kids who have head and neck hemangioma, particularly around the beard distribution, may have subglottic hemangioma. And they resolve with a bit of steroids, but the answer to this is going to be propranolol. And this child has got hemangioma that goes all the way to the carina on the left side, pretty extensive one. What can we do about some of these things? We can balloon them. It's fun. We play Don't Forget the Balloon. We can split the cricoid and put a cartilage graft to expand the cricoid. That's also fun. Or we can cut the segment that is actually narrow and just rejoin the rest. That's also fun. Sometimes on ECMO, on bypass, tracheostomy, and a few other things as well. And then I'm going to just finish off with tracheal pathology. Tracheomalacia. Often it's going to be one of two things. One is due to compression from the outside or due to the weakness on the inside. The compression from the outside will be, rings, vascular rings, abnormal heart. And then the compression from the inside will be things like tracheophageal fistula that has weakened the back wall as well. So it's a C-shaped ring that has got its legs spread out. And a lot of time the treatment for this is going to be a positive pressure ventilation rather than, stent or resection or anything like that. And then you've got tracheal tumors and lesions as well, and infection. And again, easy to fix. You've got a narrow tube. So you cut the narrow segment, split the front, split the bottom, and join it up together. So instead of one long, thin segment, you have a shorter, fatter trachea to help you breathe. That's the trachea part. I'm going to... That was what you felt. I hope I've given you just a little bit of an overview, or a degustation menu of how to actually think through things. The quality of the stridor or stertor might actually give you an indication, and just using a headlight and small little sucker, you might actually pass a tube and find where the problem or the resistance is. Now, one other thing that I just want to close with, we're all here for the kids. Now, we should really honor the people who designed this conference. One of their tagline is making a difference. And I think they've made a huge difference by deciding that this is not a conference about a craft group. This is a conference about the patient. So it's good to see that there's, midwives, nurses, surgeons, emergency physicians, pediatricians standing on a platform, because we need to break down the silos. And I think it's a great thing that these guys have done in breaking down the silos to say that this is a conference about the child, not about a particular craft group. Thanks very much.